Assalamu alaikum. Today I am going to present to this topic on the approach to the joint pain. That will be including the part 2 of the previous class. I think most of you attended my previous class, and in the previous class I told you about the basic pathologies of the joint pain, and today I will discuss the rest part of the approach to the joint pain, and that will be including the history, the signs and symptoms, and which can be elicited by taking the proper history and by going for the clinical examination. And rest of the part will be including the clinical examination of specific joints. So let's start the class. I'm going to show the slides to you. You see, I think I told you earlier about the joint pain history. And to take the joint pain history actually is very important to go for the early assessment of the clinical examination and early assessment to go for the exact pathology of the joint sign symptoms. And that's why aim of evaluation is to localize the source of the joint sign symptoms and to determine the types of the pathologic processes. Without taking the proper history, actually, we can't think of the specific joint pathologies. We can't determine the pathological process and what are the cause behind the sign symptoms. And that's why history taking is very important. Before taking the proper history taking, actually, without taking the proper history taking, we can't go for the clinical examination. We can't think of the aim to go for the clinical diagnosis. That's why history taking is very important for the students. And the history taking is very important to know whether the pain is coming from the joint, whether the pain is coming from the adjacent structures, or it is coming from the referred pain from a visceral organ or the nerve root. You see, I want to tell something over here. If you think of the pure joint pain, definitely that will be confined over the joint or in the surrounding area of the joint, but mostly the patient will feel the pain within the joint and that will be associated with the movement of the joint. Okay. But if you think of the adjacent structures which will produce the joint pain, and that joint pain won't be confined within the joint, and definitely that will be felt in the surrounding areas of the joint. Like if you think of the bursitis, the patient will feel the pain over the bursal area, and the pain though that will be within the or surrounding the joint, but still the pain will be over that specific joint part that will be in the adjacent part of the joint. And that's why tenderness will be there outside the joint, but not within the joint. That's why the adjacent structure evaluation is very important. And another one is the referred pain from the visceral organ. If you think of the cholecystitis, you know, from the cholecystitis, the pain sometimes be referred to the shoulder joint, and that will be confined over the right shoulder joint, and due to the same innervation. And that is the referred pain from the visceral organ. And sometimes the nerve root irritation might cause some kind of pain, that is the referred pain or the radiating pain. If you think of the spinal stenosis, the patient might feel the pain in the hip joint other than the spinal structures. And that time the patient might also feel the pain over the joint. So these things actually must be known to you from where the pain is coming, whether this is coming from the joint or whether this is coming from the adjacent structures like the bursa or the tendons or the ligaments, or whether this is coming as a referral pain from the viscera or radiating pain from the nerve root. Okay, so I'm going to the next slide. I want to quote here one example regarding the hip pain. You know, the hip pain, osteoarthritis will be confined within the hip joint, and that will be felt over the anterior aspect of the hip joint mostly. And if you think of the trochanteric bursitis, the patient will feel the pain over the lateral aspect of the hip, and that will be felt mostly on pressure, and that will be having some tenderness, and the patient will feel the pain during lying down on the affected side. So that is the feature of the trochanteric bursitis. And in case of the degenerative disc disease, the patient might also feel the pain in the hip joint, and that could be due to the radiating pain due to the nerve root irritation, and that will be also confined over the lumbar spine. And along with this, the patient will also feel the pain over the hip joint. So that will This kind of degenerative disc disease will also cause the pain if the hip joint, on the hip joint as well. And another one is the spinal stenosis of the lumbar spine. Earlier I told you about this example. The patient will feel the pain purely on the hip joint, and that will go down the lower limb along the distribution of the femoral nerve or the sciatic nerve without feeling the pain over the lumbar spine. So this kind of pain must be evaluated properly. You see, I'm showing here two pictures. Number one is, I think you can easily see the movement of the cursor. You see, this is the diagrammatic picture of the osteoarthritis of the hip joint. You see the erosion of the cartilage over the head of the femur, and the osteophytes are formed over here, and the disc and the space in the joint is reduced over here. And that is, and on the right hand side, this is the counter X-ray image of the hip joint. You see there is subcondylar sclerosis, and the joint is narrowing is there, and some kind of osteophytes production is there. So this is the exact X-ray picture of the OA hip. And this kind of osteoarthritis of the hip joint will produce pain within the hip joint itself, and that will be felt over the entire aspect of the hip joint purely. Another picture is showing the trochanteric bursitis. You see the trochanteric bursa is there. I think you can see the movement of the cursor, and the bursa is inflamed and it is a bit swollen over here. And here on the right hand side, I'm showing the exact pathology of the bursitis, and the patient will feel the pain over there. Okay. And you see, whenever this is the normal picture of the bursa over the trochanter, that is the normal trochanteric bursa. And whenever the patient will have the bursitis, on the left hand side, I'm showing with the movement of the cursor, the patient will have the inflamed tender bursa, and the patient sometimes will have the stiffness of the joint due to the pain, and the patient might have the tenderness over the affected area, and sometimes the patient might be having some kind of erythema, that is the reddish tinge of this, very important. And this kind of pain will be felt purely over the lateral aspect of the hip joint. Okay. And if the pain is from the joint, we must have to know whether the pain is associated with the inflammatory pain, or whether the patient is having the mechanical pain, or the patient is having the arthalgia, and that will be associated with the trauma or the joint stress. From your background knowledge of the inflammatory pain, you know the inflammatory pain will be having the night pain, or in the early morning the patient will feel more pain, and during the activities or during the mechanical movement the patient will feel better from the inflammatory pain. But whenever the patient will go for the resting condition, during the late night or early in the morning, the patient will feel more pain. So this is the characteristic of the inflammatory pain. It happens in case of synovitis or enthesitis. And synovitis happens in case of the rheumatoid arthritis, and enthesitis happens in case of the seronegative spondyloarthropathy or seronegative arthritis. I think in the previous class, I told you about the synovitis and enthesitis. Okay. And whether the pain is the non-inflammatory, and that will be also associated with the osteoarthritis of the joint. You know, the osteoarthritis, it is the degenerative process of the joint, and this is not purely associated with the inflammatory pain. And the patient will be having the mechanical pain. That is, the patient will feel the pain during the movement, during the activities. And whenever the patient will go for the resting condition, whenever the patient will go for the sleeping condition, the pain will go off. So this is the pure picture of the degenerative osteoarthritis. Okay, and that is not associated with the inflammatory pain. But sometimes there could be some kind of synovitis. So in that case, the patient will be having the mechanical pain and the inflammatory pain as well, along with the osteoarthritis. And another pain could be due to the arthalgia. You know, the arthalgia means simply the pain in the joint that is not associated with the inflammation. And this kind of arthalgic pain will be felt in the joint due to the trauma or joint stress. Say due to any kind of road traffic accident or due to any kind of sports injury, the patient might be having the arthalgia, and that won't be associated with the inflammation. And one thing is very important, that joint pain and tenderness, actually that could be sometimes influenced by the emotional state and the pain threshold of the patient. You know the pain threshold, it happens actually less in case of female, and pain threshold is more in case of male. And that's why with the same inciting factor of the pain, in case of the joint pain or in case of any kind of mechanical pain, the female will feel more pain, and in comparison to that, the male will feel less pain due to the strength of the threshold. In case of the female, the strength of the threshold is less, that is the pain threshold is less, and in case of male, the pain threshold is more. That's why with the same stimulating factor of the pain, in case of male, the pain will produce more sensation in case of female, and in case of male, the stimulating factor will produce less painful sensation. So this is very important. So joint pain and tenderness will be influenced by the emotional state of the patient and the pain threshold. Okay, I'm going to the next slide. And now I'm discussing some of the symptoms of the joint, along with the arthritis or the mechanical stress over the joint. First of all, the pain will be there. Earlier I told you about the inflammatory pain and the non-inflammatory pain. In case of the inflammatory joint disease, the patient could be having the rheumatoid arthritis or seronegative spondyloarthropathy. And the patient will feel the pain both at rest or with the motion. But mostly the patient will feel the pain during the resting condition. But whenever the inflammation will be lasting long, the pain will be felt during the activities as well. And that will be worse at the beginning than at the end of the usage. Earlier I told you about the inflammatory pain. Due to the inflammatory pain, the patient will feel the pain in the late night or early in the morning. Whenever the patient will go for the movement, the pain will reduce down for the sensation of the inflammatory pain. And in case of the non-inflammatory joint disease, which is found in case of the osteoarthritis or the trauma, and the pain will be there during the motion of the joint. So that time the patient will have the pain with the mechanical activities, and definitely that will reduce down with the resting condition. Whenever the patient will maintain the rest of the specific painful joint, the patient will feel better with the non-inflammatory joint pain. Okay, so I am going to the next slide. Another symptom is the stiffness. You know the stiffness, that is the tightness of the joint due to the inactivity. Actually, in case of the inflammatory arthritis, that will remain for a long time. And according to some studies, it was found that the stiffness might remain mostly 30 to 60 minutes in case of the initial stage of the inflammatory joint pain. Okay, or it might remain for longer time in case of advanced inflammatory arthritis, say in case of advanced rheumatoid arthritis, or in case of seronegative spondyloarthropathy, the patient might even feel the pain throughout the day. So that is very important thing. And the patient definitely will feel the pain during getting up from the sleep. I showed over here that that will present upon waking up. Okay. And another pain is the non-inflammatory arthritis that will be associated with the osteoarthritis or the trauma. And in that case, the patient might also feel some kind of stiffness, but that stiffness won't remain for a long time. At best, that might remain for at best 15 minutes, but not beyond that time limitation. And definitely the patient will have this kind of stiffness after getting up from sleep or after waking up from the sitting posture, but that won't remain for a long time. But sometimes following periods of inactivity, the patient might have some kind of tightness and stiffness without having the sleeping condition. That time the patient will feel some kind of tightness of the joint in the initial few steps of the walking. And after walking for a few minutes, the patient will feel better from the tightness. That is called as gelling phenomena. Gelling phenomena. So that is very important feature of the osteoarthritis. Okay, I'm going to the next slide. You see, that is the joint stiffness. The patient is having the joint stiffness of the spine, and during getting up from sleep, the patient feels so severe tightness, and even with the pain, the patient might have some kind of gnawing sensation, and that will be agonizing for the patient. Okay, and that happens due to the spondyloarthropathies or the ankylosing spondylitis. Okay, I'm going to the next slide. And another symptom of the joint pain is the swelling. You know, the swelling happens due to the synovitis or due to the synovial effusion or due to the inflammation of the periarticular structures like the bursitis, or in case of the synovitis or in case of the septic arthritis, the patient might be having this kind of inflammatory arthritis along with the swelling. And sometimes this kind of swelling might be found in case of the non-inflammatory arthritis, and that will be associated with the bony nodular formation. That is called as the Bouchard knot, or the another one is the Haberden's knot. Okay, so this will be associated with the bony projection, and that this happens due to the formation of the osteophytes, that is the along with the bony swelling. Okay, I'm showing some of the pictures. You see, the patient is having the rheumatoid arthritis and the patient is having the nodule, and this happens due to the synovitis. Okay, in the next picture I'm showing the degenerative nodules. You see, whenever the degenerative nodules happens in the distal interphalangeal joint, it is called as the Haberden's knot. Here in the right hand, on the right hand picture I'm showing the Haberden's knot, and in the proximal interphalangeal joint the patient will be having the Bouchard's knots. So these kinds of knots happens in case of the nodular osteoarthritis or the generalized osteoarthritis. So these are very important things. Okay. And another joint symptom is the limitation of the range of motion. That is, the patient might have some kind of tightness of the joint, and the patient might be having some kind of limitation of the range of motion. The patient can't go for the total range of motion activities of the joint. And these might happen due to the structural joint damage, that might happen due to the osteoarthritis or advanced osteoarthritis. And this might be associated with the inflammatory arthritis like the rheumatoid arthritis or seronegative spondyloarthropathy or seronegative arthritis. Or sometimes the patient might be having the contracture of the surrounding soft tissues, and that could be associated with the fixed flexion deformity. Okay, I will show some of the pictures of these things. So these are very important things, that range of motion limitation of the joint might be due to the advanced osteoarthritis or due to the inflammatory rheumatoid arthritis or the seronegative spondyloarthropathy or seronegative arthritis, or sometimes due to the fixed flexion deformity. Okay, I will show some of the pictures. And what happens due to the limitation of the range of motion? The patient will have some kind of disability in performing the ideal activities. That if you think of the buttoning of the shirt, cutting of the toenails, climbing stairs, or combing hairs. So these are the ideal activities performed by each individual, and this will be interrupted due to the limitation of the range of motion. So ultimately the patient will be having the disability due to the limitation of the range of motion. Okay, you see the patient is having the fixed flexion deformity of the right elbow, but the left elbow is okay, and the patient can go for the extension of the elbow on the left hand side. On the right hand side, the patient is having the fixed flexion deformity, and that actually is having the 45-degree angulation of the fixed flexion deformities. Okay. And another symptom of the joint pain is the weakness. Actually, due to the immobility, due to the joint pain, due to the immobility of the joint, the patient will be having the worsening of the muscles surrounding the joint. And as a consequence, the patient will lose the strength of the muscle. You know from your background knowledge that inactivity of the muscle or inactivity of the joint will reduce the strength of the muscle by 1% in a day. So that this is very important thing. So that's why whenever the patient will be having the pain in the joint, or whenever the patient will be having the synovitis in the joint, the patient will be actually maintaining some kind of inactive posture of the joint. So ultimately, the surrounding muscle will lose the strength. The surrounding muscle will lose the bulk of the muscle. So ultimately, the muscle strength will be lost over here. So this is very important thing. And another very important thing is that weakness with the pain. suggest a musculoskeletal cause, mind it. But if the weakness is not associated with the pain, we might think of the myopathic pain or the neurologic cause. But whenever the muscle weakness is there along with the pain over the specific joint site, we might have to think of the arthritis or the tendonitis. But whenever the patient will be having the pure weakness without any kind of joint pain or the periarticular pain, so that time we will think of the pure weakness due to the pure musculoskeletal cause, that is the arthritis or tendonitis. Okay, I think it is clear to you. I'm going to the next slide. You see the patient, actually this is a diagrammatic picture. This is the atrophied muscle. Due to the inactivity of the muscle, due to the immobility of the joint, ultimately the indirectly that will affect the activity of the muscle. So ultimately the muscle will be atrophied or dystrophied. But if you think of the normal muscle, the bulk is maintained over here due to the activity of the joint. So ultimately the bulk of the muscle is well maintained over here. But if you think of the disuse of the muscle, the patient will be having this kind of atrophied muscle. Okay. You see, whenever the patient will maintain the activities of the muscle, the well built of the muscle will be there. Okay. I think you can see the movement of the cursor, but whenever there will be inactivity of the muscle, the same muscle will be losing the total bulk of the muscle by almost 50%. So as a consequence, due to the loss of the bulk of the muscle, the patient will lose the strength of the muscle as well. Okay. Another picture of the disease atrophy. The patient is having the wasting of the leg muscles due to the osteoarthritis of the knee joint. So this is another picture of the disease atrophy due to the joint pain. And another symptoms could be the fatigue. What is the fatigue? Fatigue is the tiredness due to the labor. Whenever we are doing some strenuous activities or some laborious activities, we feel sometimes so much tiredness. So that is called as fatigue. In case of joint pain or the inflammatory polyarthritis, or in case of inflammatory arthritis, the patient will feel the fatigue in the afternoon or early in the morning. Okay. And that will be associated with some kind of systemic problems. But in case of the psychological disorders affecting the joint, the patient will feel the fatigue in the early morning. And sometimes this kind of fatigue could be associated with the poor sleep. So the difference between the inflammatory arthritis fatigue along with the psychological arthalgia, so the fatigue difference will be there. In case of the arthritic condition, the fatigue will be in the afternoon or early in the morning. In case of psychological disorder affecting the joint, the patient will feel the pain early in the morning, and sometimes the patient might be having some kind of associated sleep disturbance. Okay. And if you think of the pain, actually, we must have to clarify the pain according to the temporal pattern of arthritis. That is how the pain is coming and on which time duration the patient is feeling the pain. If you think of the onset of the pain, so that time we must have to think of the pain according to the acuteness or the chronicity or the subacuteness. So if the patient is having the sudden pain or the abrupt pain, and this will definitely range from the minute to hours. So this kind of pain will be associated with the traumatic pain of the joint, or could be associated with the crystalline synovitis that will be found in case of the gout or the pseudo gout, or sometimes that could be found in case of the septic arthritis or hemarthrosis. So this kind of acute pain will acute pain duration will last from minute to hours. So this is the feature of the abrupt onset of the acute arthritis. But if you think of the insidious pain, definitely that will be having the gradual onset. And this kind of onset will last from the weeks to months. And most of the forms of the arthritis, that is the rheumatoid arthritis or osteoarthritis or any kind of inflammatory arthritis, will be having this kind of insidious pain. That is the gradual pain onset will be there. Okay. And another temporal pattern of arthritis will be classified as the duration. On the duration, that is on the duration of the symptoms. Actually, for how many days the patient is feeling from this kind of arthritis. If you think of the acute arthritis, definitely that will last for less than 6 weeks. And mostly we get this kind of arthritis in case of the viral arthritis, post-chikungunya arthritis, or hemophilic hemarthrosis. So this kind of acute arthritis will last for less than 6 weeks. And another arthritis is the chronic arthritis that will last for more than 6 weeks or more. Okay. And that will be associated with the rheumatoid arthritis or the seronegative spondyloarthropathies or seronegative arthritis. So these are the examples of the chronic inflammatory arthritis. And in between these two, acute arthritis and the chronic arthritis, there remains another entity, that is the subacute arthritis. And this kind of subacute arthritis is found in case of diabetes mellitus, in case of adhesive capsulitis of stage 2. Okay, so in this case of adhesive capsulitis, in case of diabetes mellitus, the patient will feel the pain along with the tightness of the joint, but the pain won't be as severe as acute arthritis or acute capsulitis in the stage 1 of the adhesive capsulitis. So this is very important thing. And another temporal pattern will be classified on the migratory pattern. In case of the inflammation of the joint, actually the migratory pattern pain actually will be there along with the old arthritis for only a few days in each joint. Okay, so in case of the non-migratory pattern of arthritis, only the few joints will be affected, and within the inflammatory process of these few joints, no other arthritis will be added over there. So that is the non-migratory pattern, and it happens in case of acute rheumatoid arthritis or acute rheumatic fever, or sometimes it can be found in case of disseminated gonococcal infection. Okay, and another pattern could be with the additive or simultaneous pattern. That is, the old arthritis will be associated with the new arthritis. That means the old arthritis is there, and along with the old arthritis, the new joint involvement will be there for the arthritis. That will be found in case of seronegative spondyloarthropathy or seronegative arthritis or rheumatoid arthritis. So this is very important thing. And sometimes the patient might be having the intermittent pattern of the arthritis. And definitely the patient will be having the episodic involvement of arthritis. And in between the two episodic flare of the arthritis, in the intervening period, the patient will remain symptom-free. Okay. And it happens in case of the recurrent gout, or in case of the recurrent pseudogout or the Lyme arthritis. So in between two flare of the gout or the pseudogouts, actually the patient will be having the intervening period, which will be having no sign symptoms of the gout or the pseudogout. Okay. And another historical feature must be counted on the basis of the number of joint involvement. Okay, if only one joint is involved, that is called as monoarthritis. Another one is the oligoarthritis, where 2 or 4 joints will be involved. And in case of the polyarthritis, the patient will be having the joint involvement that will be counted for more than 5 or more joints. Mind it. So in case of monoarthritis, the patient will be having only single joint involvement. In case of oligoarthritis, the patient will be having 2 to 4 joint involvements. In case of polyarthritis, the patient will be having more than 4 joint involvement. That is 5 or more joint involvement could be there according to some of the books. In case of the monoarthritis, the patient might be having the monoarthritis in case of the gout or the septic arthritis. In case of the oligoarthritis, the patient will be having this kind of oligoarthritis. In case of the seronegative arthropathy, in case of polyarthritis, the patient might be having the rheumatoid arthritis. Okay. And another counted thing is the symmetry of the joint involvement. In case of the symmetry of the joint involvement, there could be the symmetrical arthritis, and another one is the asymmetrical arthritis. In case of the symmetric arthritis, this kind of symmetrical involvement of the joint arthritis is found in case of the rheumatoid arthritis or systemic lupus erythematosus, that is the SLE. And in case of the asymmetric joint involvement, we get this kind of asymmetric joint involvement in the psoriatic arthropathy or the reactive arthritis or the seronegative arthropathy. So this kind of joint involvement will be there in case of asymmetrical presentation. You see, this picture is showing the symmetrical involvement of the finger joints, that is the mostly the PIP joints are involved over here on both sides. Symmetrical joint involvement, and the patient is having the ulnar deviation of the fingers. And the patient is also having the Z deformity of the thumb on both sides. And this is found in case of the rheumatoid arthritis. You see, this is found in case of the psoriatic arthropathy, and this kind of fingers are called as sausage disease. And these are found in case of dactylitis. And along with this, the patient will be having the nail involvement. You see, the nail is totally distorted over here. And these are found in case of the psoriatic arthropathies. And another picture of the psoriatic arthropathy, the nail involvement is there, and the toes are totally deformed over here. Okay. And another very important thing is the distribution of the affected joint. The DIP of the finger joints will be affected mostly in case of the psoriatic arthropathy, gout, and osteoarthritis. Okay, mind it. So in case of osteoarthritis, whenever the DIP will be affected, that will be called as the Haberden's node. Okay, but whenever the interpharyngeal joint, the proximal interpharyngeal joint will be involved in case of the nodular osteoarthritis, that nodular swelling will be called as Bowker nodes. Okay, so these are very important things. And in case of the lumbar spine, mostly in case of the inflammatory arthritis, lumbar spine will be involved in case of the ankylosing spondylitis. But in case of the rheumatoid arthritis, lumbar spine is mostly spared. Okay, but in case of the other spinal part of the spine, the cervical 1 and cervical 2 joint will be affected in case of the rheumatoid arthritis. But the spinal involvement happens in case of rheumatoid arthritis only in case of cervical 1 and cervical 2 joint. But the lumbar spine will be spared in case of the rheumatoid arthritis, mind it. Okay. So you see the picture is showing the normal bony architecture of the healthy spine. And on the right hand side, the second picture and the third picture is showing the second picture is showing the early involvement of the ankylosing spondylitis. Here, the inflammation is going on over here. Inflamed joints is there. And in the third picture, there actually some kind of tightness of the joint, and the sclerosis of the longitudinal ligament is forming the bambooing of the spine. I will show some of the X-ray pictures for the bambooing. You see the patient is having the normal architecture of the spine. And here the patient is having the ankylosing spondylitis. You see both two vertebrae actually are having the fusion for the formation of the syndesmophyte, part, and that will produce the bambooing of the spine. And this is found in case of ankylosing spondylitis. You see the patient is maintaining the stoop posture due to the ankylosing spondylitis, and there is some angulation. And if you go for the comparison in between the normal person and the stoop person having the ankylosing spondylitis, so definitely there is chin brow to vertical angle, so that is 30 degrees, and that can be measured by the goniometer. Okay. You see on the left hand side, the patient is having the normal architecture of the spine on the X-ray. On the right hand side, the patient is having the bambooing of the spine due to the calcification of the anterior longitudinal ligament. So this is called as bambooing of the spine. You see there is no gapping in between the two vertebrae here on the right hand side, but in the normal X-ray image, you are getting the gap in between two vertebrae. Okay. And here I mentioned some of the distinctive types of musculoskeletal involvement in a specific joint arthritis. In case of the spinal arthropathy, the patient will be having the enthesitis, the patient will be having the dactylitis, and which is found in case of the psoriatic arthropathies mostly. And it is also called as sausage disease. And sometimes the patient will be having the tendonitis and the inflammatory back pain. You see here, I didn't mention about the synovitis. So in case of spondyloarthropathy, the patient will be having the pathologies, the basic pathologies of the joint inflammation other than the synovitis. But in case of the rheumatoid arthritis, the patient will be having the synovitis. And sometimes there could be some kind of enthesitis, but or the tendonitis, but these are very rare in case of the rheumatoid arthritis. But these are very common in case of the spondyloarthritis. And the synovitis is very rare in case of spondyloarthritis. So mind it. And in case of the gout, the patient will be having the involvement of the tendon sheath and the bursa, and sometimes the synovium. So ultimately, the patient will be having also the synovitis. And due to the involvement of the tendon sheath and the bursa, the patient will be having the superficial inflammation. Mind it. You see, this picture is showing the dactylitis of the finger joints. Okay, and there is some kind of distortion of the joint architecture. You see, the patient is having the bursitis in case of the gout. Okay, that is the bursitis over the elbow joint. And there could be some other extraarticular manifestations along with the arthritis. And these are very important counted things. Whenever the patient will be having the inflammation of specific joints due to any kind of inflammatory disease like the SLE or the dermatomyositis or the psoriatic arthritis, and along with this, the patient will be having or would be having some kind of extraarticular manifestations. I will show some of the things later on. You see, the SLE patient will be having this kind of butterfly rash. Okay, on both sides you are getting the butterfly rash. And the patient of the dermatomyositis will be having this kind of skin lesions. Okay, the patient of the dermatomyositis will be having this kind of problems on the skin. And this is the feature of the scleroderma. You see the shiny pinkish and reddish tinge of the skin of the specific joint. You see the patient is having the scleroderma. Okay, and sometimes the patient might be having the erythema nodosum. Okay, you see these are the tender erythematous subcutaneous nodules, and these are painful. And I will show some of the these entities from where we will get the erythema nodosum. You see, due to some drugs, due to some infection like the hepatitis C, tuberculosis, Streptococcus, mycoplasma infection, Yersinia infection, so the patient might be having the erythema nodosum. And some kind of, in case of some systemic diseases, the patient might be having the erythema nodosum like the lymphoma, leukemia, or lupus disease, or the sarcoidosis. The patient might be having the erythema nodosum. Okay, you see the patient is having the psoriatic plaque over the joint due to the psoriatic arthritis. I am showing some of the pictures of this. And the some extraarticular manifestations could be found in the eyes in case of some kind of inflammatory disease like the rheumatoid arthritis. In case of the rheumatoid arthritis, the patient might be having the episcleritis or scleritis. In case of ankylosing spondylitis, the patient might be having the anterior uveitis. In case of juvenile rheumatoid arthritis, the patient might be having the iridocyclitis. In case of the rheumatoid reactive arthritis, the patient might be having the conjunctivitis. I will show some of the pictures later on. You see, the patient is having the episcleritis. The patient is having the scleritis. The patient is having the anterior uveitis. This patient is having the iridocyclitis. Okay. You see, the conjunctivitis is there. So now I will discuss some of the physical signs and symptoms which can be found after clinical examination, after doing the clinical examination of the joint. We'll get some of the nodules in case of the synovial hypertrophy, in case of the rheumatoid arthritis, and sometimes we will get some of the joint diffusion in case of synovitis as well. And sometimes the patient might be having the pain during the active range of motion, and it happens mostly at the extremes of the joint portion. Okay, so these are the signs we will get during the clinical examination of a specific joint. And you see the nodules, these are the rheumatoid nodules in case of the rheumatoid arthritis on both sides. This is the effusion. sorry, this is the effusion of the knee joint due to the rheumatoid arthritis. And sometimes the patient will have the pain with the motion. If the pain with the range of motion is there throughout the range of motion, whole range of motion, so that time we will think that the patient is having the acute inflamed joint. But if the pain is not there in the entire range of motion, but in some specific degree of angulation, the patient is having the pain, that will be definitely coming from the extraarticular sources, that is the tendinitis. Okay. So if the patient is having the pain due to the whole range of motion, so that time that could be due to the synovitis. But whenever the patient will be having the pain in some specific point of range of motion, so that time we will think of tendinitis. You see, the patient is going for the movement of the knee joint from the flexion up to the extension. So if the patient is having the pain in the throw in the whole range of motion, so that time we will think of the synovitis of the knee joint. But if the patient is having the pain in some specific point of the range of motion, we will think it otherwise. And definitely that pain is not coming from the synovitis. You see, I'm showing over here some ranges of motion of specific joints. No need to understand these things right now. And sometimes we will get some of the erythema and the warmth after doing the clinical examination. And the erythema, you know, the reddish tinge of the skin happens due to the inflammatory arthritis. In case of the acute arthritis, we will get the erythema like the sometimes we will get the erythema in the gout, in the septic arthritis, or so these are the erythema in case of the rheumatoid arthritis in the finger joints and on the palm. You see the patient is having the erythema. You see the patient is having the erythema. And the erythema due to the gout. You see the patient is having the erythematous reddish tinge in the gout on the first metatarsalophalangeal joint. You see the patient is having the erythema, reddish tinge of the skin due to the septic arthritis, due to this found in case of the acute rheumatic fever. Okay. And another sign is the joint tenderness. If the pain is there along with the tenderness, and if this is the focal tenderness, so definitely that will be involving the tendinitis, that will be involving the bursitis or osteomyelitis. And if there is tenderness in absence of other joint pathologies, we must think of the patient's emotional state. So that time we might think it otherwise. Mind it. So in case of the focal tenderness involving the joint pathologies, we must have to think of the tendinitis, bursitis, or osteomyelitis, or some other things. But whenever the patient won't be having any kind of joint pathologies, but still the patient is having the joint pain, we might think of the patient's emotional state. That could be associated with the functional disorder. And I will tell some of the signs of the osteoarthritis or the mechanical joint diseases. First of all, we'll get some kind of bony overgrowth, that is the osteophyte. Earlier I told you about this. In case of the distal interphalangeal joint, there could be some kind of osteophytic nodular formation that will be termed as the Hayward's node. And if the distal proximal interphalangeal joint will be involved, that will be called as the Bowker nodes. You see, the DIP is involved in case of nodular osteoarthritis. This is called as Hayward's node. And in case of the PIP, nodular osteoarthritis, it will be termed as the Bowker node. Okay. And another very important thing is the limited range of motion. Whenever the patient will be having the joint pain, along with the limited range of motion, we will count three things. Number one is the interarticular loose bodies. That could be associated with some kind of limbus formation or some kind of the bony island within the joint. So that will result in the limited range of motion. And sometimes we will get some limited range of motion due to the osteophytic formation. And sometimes due to the subluxation or the dislocation of the patient might be having the limited range of motion. Mind it. Okay. I will show some of the pictures of this. You see here in the knee joint on the left side, the patient is having the island of the bones. These are the loose bodies. These are the calcified loose bodies. And this will actually interrupt with the total range of motion of the joint. You see on the right hand side, there are also two loose bodies inside the knee joint. Okay. And you see the patient is having the normal anatomy of the glenohumeral joint, but in case of the anterior dislocation, in the same picture, you see the patient is having the anterior dislocation of the shoulder. And here, the subluxation and the dislocation will be there simultaneously, and the posterior dislocation will be there. Ultimately, all these anterior or the posterior dislocations will produce the